Hi there, my name is Mike Pishvaian. I'm an associate professor at Johns Hopkins University School of Medicine in gastrointestinal oncology, and it's my pleasure today to welcome you to our first Tumor Board Tuesday webinar. This one's called Overcoming Disease Recurrence and Treatment Resistance in HER2-positive metastatic tumors, Awareness and Testing, and the Mechanisms of HER2 family receptors. I'm joined today by really an all-star group of experts in this area, starting with Dr. Aatur Singhi, who is an associate professor of pathology at University of Pittsburgh Medical Center, as well as Dr. Minetta, who is a professor of oncology and the research chair in the Department of Oncology at Mayo Clinic in Rochester. And finally, Dr. Emanuel Petricoin, who is a professor at George Mason University and co-director of the Center for Applied Proteomics and Molecular Medicine. So thank you all for joining us today. We have our disclosures up on the screen. And today, over the course of our discussion, we're going to complete the following objectives. We're going to describe the bidirectional contribution of HER2, HER3 as prominent pathobiological drivers of treatment-resistant subtypes in gastrointestinal and lung cancers, as well as breast cancer. We're going to elucidate the mechanisms of action and clinical trial findings of recently approved and emerging HER2, HER3 targeted drugs for multiple tumor types. And we're going to examine the guideline-recommended HER2 testing for patients with breast cancer, gastrointestinal cancers, and lung cancer. And so with that, let's start the talk off. We're going to hand it over to Dr. Liu to talk about the prevalence of HER2 overexpression in tumors.
Thank you very much, Dr. Pishvaian. It's a pleasure to be here today with this very esteemed panel. I'm here to talk about prevalence of HER2. Next slide, please. So HER2 is a promiscuous but prominent member of the EGFR family of oncoproteins. And as you can see on the cartoon on the right, HER2, as well as its co-family members, HER1, HER3, HER4, are proteins that dimerize. They're called homodimers and heterodimers, and with the exception of HER2, have a wide variety of ligands. HER2, the protein, is encoded by ErbBB2, which is the gene, and HER2 is frequently altered in cancerous tumors, particularly in breast cancer, and it's one of the few targetable molecular drivers of aggressive cancer. HER2 activity in malignancies is mostly marked by protein overexpression, which correlates with varying degrees, as you'll hear later, with gene amplification. There's also a growing acknowledgement of activating mutations that lead to constitutive activation of HER2 in the absence of protein expression or gene amplification. Next slide, please. HER2 alterations, be it mutations, protein overexpression, or gene amplification, occur in multiple cancer types. They range from about 25% of cases in breast cancer, 22% of cases in gastric cancer, 32% in GE junction tumors, it's 5% in colorectal cancers, and in non-small cell cancer, it's more towards the 6%, but ranges to 6 to 30% have been reported. Interestingly, as you look at the figure on your right-hand side, how HER2 is defined in terms of its activity by amplification, which is in the blue, overexpression in the green, and HER2 mutations in the gray, that distribution of HER2 quote-unquote positivity will vary with differing malignancies. So there isn't an absolute correlation as one might expect between gene amplification and protein expression, and you'll hear again more about that later. Next slide, please. HER2-driven tumors are almost uniformly characterized by poorer overall survival. And if you look in non-small cell lung cancer, so this is an advanced stage disease with HER2 defined by activating mutations, whether there's therapy administered targeting HER2 or not, HER2 tumors that carry HER2 mutations have inferior median overall survival versus those that are wild type, in other words, without a mutation detected. If you look in gastric cancer, so these are across all stages of disease in the absence of any HER2-directed therapy, definitions of HER2 typically by immunohistochemistry or looking at the protein level. HER2-positive tumors tend to have worse median overall survival than HER2-negative tumors. It gets even more complicated if we look at breast cancer, which is in the figure on your right-hand side. If you're looking at breast cancer subtypes defined by hormone receptor status, HER2 status, as well as tumor grade, you can see that when you clump all the HER2 overexpressing tumors together, and that's represented in the yellow line, survival is worse and only superseded by triple negative breast cancers. Interestingly, if you look at the luminal B tumors, which are hormone receptor positive tumors of high grade, and look at the differentiation between HER2 and negative and HER2 positive tumors, again, HER2 is a very active player, separating those with worse versus better overall survival. Next slide. With this aggressive cancer phenotype, these patients who have HER2-driven tumors tend to have a higher risk of disease recurrence and a higher risk of distant metastatic disease. If you look at progression-free survival in patients with advanced or metastatic disease who are receiving standard of care treatment for HER2-positive tumors, whether it's in later lines of therapy, as in breast cancer or gastric cancer, or even in first-line therapy for lung cancer, median progression-free survival is less than 5 months almost across the board. Next slide. The good news is that HER2 is a useful therapeutic target, and there are increasingly new strategies to target HER2 and the Her family of receptors. There are multiple targets, and they will vary across multiple cancer types. And the different strategies that target HER2 include inhibiting receptor dimerization, promoting receptor internalization and or degradation, engaging antibody cytotoxic activity, targeting the delivery of highly cytotoxic agents, and that's sort of all the rage now with our antibody drug conjugates. We can also directly inhibit the downstream tyrosine kinase domain and achieve dual targeting of trastuzumab and pertuzumab binding sites. So there are a lot of permutations for how we can target HER2, and all of these permutations are geared towards improving survival. As a result, HER2 testing is mandated. It's strongly recommended by the NCCN guidelines for specific tumor types that include breast cancer, gastric cancer, GE junction tumors, and colorectal cancer. And again, newer agents have improved efficacy in patients with HER2 positive breast cancer, traditionally defined, but also with HER2 low disease. And that's a growing area of interest, trying to expand the armamentarium of therapy for patients who don't have traditionally HER2 positive breast cancer. Next slide. So now I'll open it up to the panel discussion.
Thank you, Dr. Liu. That was an excellent and concise review on HER2 alterations. And I think this is a great opportunity to pause and discuss many of the important points that Dr. Liu mentioned regarding HER2 status. In fact, one aspect that I found intriguing is that HER2 status across many tumor types is not only important therapeutically, but also prognostically. Dr. Liu, is it fair to say that amongst the different mechanisms of HER2 alterations that include what you reviewed, which was HER2 overexpression, ERBB2 amplification, and ERBB2 activating mutations, all three of these alterations are probably considered a universally poor prognostic finding?
The data would suggest that, but again, we have to remember that although there may be an association with poor prognosis, we do have very effective therapies. So I don't want people to walk away, with the thought that HER2 positive breast cancer is just uniformly bad. Again, it's a strategy that opens the door to an entire class of drugs. I think one important thing to stress as well is that how HER2 positivity is defined will vary across malignancies. Right, lung and breast are very different in terms of what defines how HER2 is acting, and those are careful considerations for us as we think about our targeted therapies.
And as a secondary question to not only Dr. Liu, but the rest of the panel, when it comes to testing for these three types of HER2 alterations, should we be performing HER2 reflexively, or should a more selective approach be adopted when it comes to testing?
I think that's an interesting question. And I think with the advent of kind of more comprehensive, in some ways multi-omic analysis of some of these analytes at the gene and protein level, and maybe at some point at the gene expression level, depending on the tumor type and even the mechanism by which HER2 is activated and functionally in use, we also can't ignore the fact that HER2 is naturally activated by homodimerization and heterodimerization with the receptors that have their own ligands. And so you can even get ligand-driven activation, if you will, not through HER2's ligand, obviously, but through the ligand of the other HER family members that, depending on the HER2 status, can drive signaling through HER2 as a preferred binding partner. And this is a growing area.
Thank you. I guess my last question to the panel, which is, I guess, oddly somewhat self-serving, is as far as it's being the next topic that I'm going to be talking about, but are HER2 alterations heterogeneous within a tumor, and do they change over time? So should we consider repeat testing of patients as they get treatment?
Yes.
Simple question there. I guess maybe I can get into that a little myself, and then we'll talk about that later. But once again, thank you, Dr. Liu, and the rest of the panelists for really a nice insight in HER2 alterations. And I guess this is a nice time, if we can go to the next slide, to really talk on really how do we transition really the first steps in identifying patients with HER2 alterations, which isn't trivial and in many cases tumor type dependent. Can you go to the next slide? In my opinion, by far, our greatest understanding of HER2 positive cancers, and I think a lot of our panelists will agree, is based on what we've learned from breast cancer over the past few decades. And as such, any newly diagnosed breast carcinoma, as Dr. Liu had mentioned, as well as any relapses or metastatic deposits, HER2 testing is unequivocally recommended. In addition, in 2018, within a joint ASCO, CAP, and even NCCN guidelines, regarding testing recommendations for breast cancer, the panel of experts suggested HER2 testing may be repeated if any of the 4 scenarios should occur. First, that being the amount of invasive tumor in a prior core biopsy specimen is small. Second, the resection specimen containing a high-grade carcinoma that is morphologically different from the core biopsy that was previously taken. The third, the core biopsy result is equivocal for HER2 after testing. And fourth, if there is any doubt about the handling of the core biopsy specimen, such as long ischemic time, short time in fixative, or a different fixative than really advocated by the current recommendations, or even if the test is suspected by the pathologist just to be wrong on the basis of a testing error. All of these scenarios are an indication to or for repeat HER2 testing. Can you go to the next slide? And so with regards to testing, joint ASCO and CAP recommendations state that a tiered testing approach should be used. This should include immunohistochemistry as the first screening method. And then for certain cases, such as equivocal cases by immunohistochemistry, the next step would be utilization of in situ hybridization methodology. Ideally, an in situ method or in situ hybridization method should make use of fluorescence, chromogenic, or silver enhanced probes. Further, it should include a corresponding chromosome 17 probe to determine exact copy number ratios for HER2 or ERBB2 amplification. Of course, in certain instances where tissue can be limited and other potential actionable targets are of consideration, next-generation sequencing has certainly become an important tool to assess ERBB2 amplification. Moreover, it's become clear that overexpression of HER2 is not only through ERBB2 gene amplification, as Dr. Liu had mentioned, but also through acquisition of ERBB2 somatic alterations that can occur in up to really 3% of breast cancer patients. Now, as Dr. Liu mentioned, other tumor types can harbor HER2 or ERBB2 alterations. And when applying this testing strategy to other tumor types, there are some notable differences to consider. For example, in gastric and gastroesophageal or GE junction cancers, they have a similar prevalence of HER2 overexpression and ERBB2 amplification as compared to breast cancer. However, heterogeneous staining for HER2 within a tumor is significantly greater when it comes to GE junction adenocarcinomas, and actually on the order of about 5 to 7%, while a similar heterogeneous staining pattern in breast cancer is an infrequent finding and on the order of approximately 1% of cases. Next slide. That being said, current ASCO and CAP guidelines have fairly similar staining cutoffs for breast, gastric, and GE junction cancers. Notable exceptions for gastric and GE junction cancers is the interpretation of biopsies versus surgical specimens, which accounts for a greater staining heterogeneity seen within the tumor type so as to identify all potential candidate patients. In addition, unlike breast cancer, there have really been no recommendations with regards to repeat HER2 testing for patients when it comes to gastric or GE junction cancers as a whole. But really, the general rule of thumb used by many GI pathologists is to perform repeat testing if the patient's prior specimen was negative for HER2 overexpression. The justification for repeat testing is to once again account for that potential heterogeneous staining. Next slide. Finally, with the advent of next-generation sequencing, to look for alternative mechanisms of HER2 or ERBB2 activation and the ability to multiplex for other potential actionable targets, including treatment-resistant mechanisms, comprehensive genomic profiling is likely the way we're going to move forward, and not only looking for ERBB2 amplification, but also what was discussed previously to include activating somatic mutations in ERBB2, for example, as those seen in non-small cell lung cancer. Next generation sequencing is, however, unlikely to replace immunohistochemistry. This is especially important to underscore considering many of the new HER2-directed antibody drug conjugates coming to the market. The clinical efficacy seen with these ADCs is likely dependent on sustained expression of HER2, but certainly it will be important to understand why HER2 is being overexpressed, and hence I foresee next generation sequencing complementing immunohistochemical testing for HER2. And lastly, it's important to note that there are many ways to molecularly evaluate ERBB2 that does not include direct tumor tissue-based testing. A good example is cell-free circulating tumor DNA assessment, which in all honesty, and maybe my co-panelists may agree or disagree, it's still in its somewhat infant stages, and while it can be used as an initial screening tool, false negative results should be considered and can occur. However, or hence why it's really currently advocated to perform HER2 or ERBB2 testing using really direct tumor tissue rather than blood-based testing, at least for the moment. And that really summarizes my area of HER2 testing itself from a pathologic point of view.
All right. Thank you, Dr. Singhi. That was great. Really got us from a pathologist perspective, which is actually one of the goals here. And as we're talking here to an audience of perhaps academics, but perhaps community physicians and academics as well, and oncologists as well, the question I have is, at a typical local pathology lab, what is sort of the minimal amount of HER2 testing that should be expected that doesn't necessarily need to be sent out?
I would say immunohistochemistry. The first-tiered analysis as advocated by CAP and ASCO is probably the minimalistic type of assay that can be performed in a routine pathology lab. It comes down to doing FISH and CISH, or chromatin in situ hybridization, or even silver-based methods, where it becomes very expensive, labor-intensive, and requires appropriate QA and QC. And to have the actual technical staff, the ability to do that, it really requires a higher volume center, and those are usually larger academic centers or a reference lab itself.
Okay, and then so if it's IHC is sort of the foundation, what kind of time frame would be expected for IHC? And before you answer that, if a lab has to send out for the subsequent follow-up tests like FISH or NGS, what kind of time frame might be expected for that for the turnaround?
So that's a great question. I think that when it comes to immunohistochemistry, a typical run is done on an automated stainer, which usually takes about 12 to 16 hours at most. But that doesn't include, preparation of the tissue itself. So I think a good rule of thumb is basically about 2 to 3 days for any lab to get done in HER2 IHC. When it comes to FISH and chromatin in situ hybridization methods, that can certainly take a much longer amount of time because, again, it needs, tissue preparation, slide preparation, as well as technician time to look for the areas that were equivocal staining and then to count all of the amplification, looking at chromosome 17 and the actual HER2 copy numbers. And I think that, on the average, should take about 7 working days.
So, Dr. Liu, with that in mind, and not to put you on the spot and have you step out of your realm, obviously in breast cancer, HER2, ER/PR, they are sent immediately or run immediately by the pathologists. But should any sample for some of these other disease types, in your opinion, gastric cancer, colorectal cancer, biliary cancer, should these be reflexively sent for HER2 testing from the outset?
I think Yes, for those malignancies for which we have HER2-directed therapies available as a standard of care, it would make sense to reflexly test. Although we recognize the prognostic significance of HER2 status across a variety of malignancies, we don't really act differently on it. So I don't know that, reflexly using that tissue, for example, in all patients is really a good source of resources, good use of resources, at least at this time, and that may change in the future.
All right. And then actually one other question, I'm going to put you on the spot again. Dr. Singhi mentioned cell-free DNA testing, but I know that you had an interest in circulating tumor cell testing. Any thoughts on using that for HER2 testing in the blood?
Sure. So, yeah, our laboratory has interests both in circulating tumor cells as well as cell-free DNA, and we've developed, as others have, assays looking at HER2, whether it's HER2 protein or BB2 amplification in circulating tumor cells, and we see a lot of heterogeneity as we do in tissue, probably more so in the blood, because you can imagine multiple tumor sites are represented in the blood. With cell-free DNA, it's just one cauldron, if you will, for what you're testing. You can pick up amplifications, and you can certainly pick up mutations. You can pick up mutations in circulating tumor cell-derived DNA as well, but because the amount of DNA is so little, as Dr. Singhi pointed out, a negative result doesn't just means it wasn't detected. It doesn't necessarily mean that it's negative. So if you really need to chase this down for therapeutic purposes, then you should reflexly test tissue if you get a negative result from blood.
Perfect. All right. Well, let's move on and dive deeper, both figuratively and literally, with Dr. Petricoin as he talks to us about HER2 activation and phosphorylation testing.
Thank you. And again, a pleasure to be here this evening amongst my esteemed panelists. So diving a little bit deeper, as Dr. Pishvaian said, into HER2 biology and perhaps other alternate ways of looking at HER2 usage or the in-use status. As Dr. Liu very nicely provided a nice overview of HER2 biology, just to level set, right? HER2 does not act alone, does not have its own ligand, at least not one identified to date, and therefore can either homodimerize or heterodimerize with HER3 as well as EGFR and HER4. It also has the other family members, especially HER3, that can also heterodimerize with other receptor tyrosine kinases like MET, IGF receptor, and other receptor tyrosine kinases as well. And this will be important as we dive in to the HER3 targeting as well. So HER2 is the preferred interacting partner of EGFR in non-small cell lung cancer and highly aggressive lung adenocarcinoma. And HER3 is the preferred binding partner in breast and ovarian cancers, although EGFR, HER2 heterodimerization, and HER2 homodimerization are also seen. In fact, HER2 homodimerization by folks like Carlos Artiega have shown that might be the preferred binding partner for trastuzumab response. So a complicated dance, if you will, of the receptors at the level of the cell membrane. Next slide, please. So it's also important to recognize that, of course, that heterodimerization or homodimerization ultimately is actionable because these drive signaling downstream and transcriptional activation. The main signaling components are the PI3-AKT, mTOR pathway, and the MEK-MAP kinase RAS-RAF pathway, as well as the JAK-STAT pathway. So those three pathways are kind of the main legs by which most RTKs, receptor tyrosine kinases, signal, and most notably the HER2, HER3 dimerization partnership. Now, HER3 preferentially heterodimerizes with HER2, as I've said. It's ligand dependent through ligands like neuregulin, but of course, there's also ligand independent, or what we call autoactivation, that's coincident with HER2 amplification. So just the stochastic amounts of HER2 can drive that heterodimerization by mass action kinetics and therefore drive downstream signaling. This heterodimerization is also involved in multiple resistance mechanisms that can occur as the patient receives different lines of HER2 targeted therapy. Next slide, please. So one of the interesting studies that I'm involved with in the notable I-SPY2 trial, which is a very well-known neoadjuvant breast cancer trial that myself and Dr. Liu work in. In this trial, women with aggressive stage 2 or stage 3 breast cancers are provided the opportunity to get different kinds of targeted inhibitors depending on their ER and HER2 status. We just published a paper in Nature Communications, the results of the TDM1 pertuzumab and pertuzumab trastuzumab arms of I-SPY2, where we found surprisingly that even in ostensibly high HER2 positive patients with HER2 positive tumors, 3+, 2+, we could very cleanly distinguish responders and non-responders, which in the neoadjuvant setting, what we call complete pathologic response is what we designate as a responder, non-responder categorization. We could very cleanly designate patients who achieve pathologic response or not by the underpinning phosphorylation or activation status of HER2, even in patients who are already HER2 positive. Now, one way that this can occur, of course, is the fact that for antibody dependent cytotoxic agents like TDM1 with the emtazine bomb on it, that drug has to get inside the cell for its mechanism of action. And one way that these get inside the cell is for receptor invagination, intravasation, and basically vacuolization. And this occurs most notably when receptors become phosphorylated or activated. That's when they recycle. So we were able to show in this two-way scatter plot, which is a two-way scatter plot of HER2 activation by phosphorylation and EGFR phosphorylation, so this double activation signal. As tumors became more highly activated, they became more frequently responsive. Patients that had low levels of HER2 activation and EGFR activation, despite being HER2 positive, almost all of those patients did not respond to therapy. And this is important, especially in clinical trials like I-SPY2, where we're interested in accelerating or deaccelerating HER2-directed therapy. Go to the next slide, please. So this is shown in this cartoon where basically, if we look at the current present day patient care management, where HER2 is being tested, as Dr. Singhi discussed, by IHC or FISH, depending on those levels, anti-HER2 treatment is prescribed. In this view to the future, perhaps, where other alternate ways of measuring HER2, such as functional activation, and looking at the activation state of HER2, we could identify patients who are destined for response or destined for non-response despite being HER2 positive. And perhaps in that instance, you could de-escalate therapy in a HER2 responding patient, such as shorten the HER2 duration or eliminate chemo backbone therapy, or in the context of escalation, e.g. a patient destined for non-response, we could think about pathway-based inhibition, basically pathway-based targeting, we call it, where you have a dual blockade, where you add pertuzumab, or you add TDM1 with neratinib, and you start to shut down the pathway. And so this is perhaps a next generation of how we're going to be looking at HER2 beyond FISH and IHC and mutation status, and that is a direct analysis of its functional in-use state. Next slide, please. So we'll now have a panel discussion for these emerging methodologies for HER2 testing. And it would be great if Dr. Liu could talk about this opportunity for deaccelerating or accelerating therapy for for HER2 by using some of these new types of methodologies that may further stratify patients who are ostensibly HER2 positive, but yet perhaps, as we know, not all those patients respond to HER2 therapy despite being, say, a 3+.
No, that's great. And thanks, Dr. Petricoin, for your amazing presentation, as always. It's not, we are in this era of precision oncology because we recognize more and more that one size doesn't really fit all, even with respect to having HER2 positivity in a subset of patients. Not every patient will benefit from HER2-directed therapy or what's considered standard of care for that setting. So to have the ability to further refine who will or will not benefit to the degree we want them to benefit, and allowing us to escalate or de-escalate therapy will help from the perspective of resource utilization, toxicity, and just efficacy, right? Particularly in the setting of escalating therapy to find the right treatments for our patients. It's critical.
No, that's very interesting in that context, of course. And Dr. Singhi, from a pathologist perspective, do you see beginning emergence of measuring, say, EGF receptor and HER3, especially HER3, in the context of these other solid tumors as an adjunct for, say, even a reflex for HER2 positive testing results?
I wouldn't say it's completely in our clinical space just yet, but certainly the antibodies are available and they're sold by multiple vendors. And we're already having cross-reaction to some of our antibodies with HER3. And so I see that definitely in the foreseeable future as being an assay that we'll be looking into in greater detail, and then developing a methodology to measure that, just like we do with HER2 when it comes to grading the expression.
Maybe even a growing importance in the context of resistance, perhaps as patients progress from HER2 targeted agents, but yet still retain a HER2 positive status. These resistance mechanisms could be actionable, from a pathology de rigor type of testing. So
Exactly.
Thank you very much. So Dr. Pishvaian, would you like to go to the next module?
Yeah, well, I think that this is you gave a perfect segue to the next segment that you're going to talk through in terms of HER2, HER3 targeted therapy and therapeutic targeting. And I'll say that this is a huge area to try and cover in just a few slides. We are going to have a follow-up webinar in a few months, so keep it on the outlook for that on more specific clinical data. But this is just to give it a little bit of a flavor of the very much growing area of therapeutics targeting these two proteins.
Excellent. Yes, and to that extent, you're right. We could be giving an hour-long talk just on this topic alone, of course. So if we could go to the next slide, please. Next slide, please. Great. So I think it's worth just revisiting, although some of this has already been discussed, the mechanism of action of targeted agents that are going after HER2 as a segue into this side. So of course we have legacy molecules like trastuzumab, Herceptin, that inhibit through direct antibody binding and suppress signal by basically preventing homo and heterodimerization. We have growing classes of drugs like pertuzumab that inhibit dimerization, then by limiting the ability to signal downstream. And then, of course, as alluded to through some of the I-SPY2 discussions, we have growing classes of antibody drug conjugates, ADCs, for example, TDM1, which is essentially trastuzumab with a emtansine bomb cytotoxic drug linked to it that is then delivered to the target intracellularly. So intracellular cytotoxic drug delivery. And then, of course, we have growing classes of receptor tyrosine kinases and tyrosine kinase inhibitors like neratinib, which is approved in breast cancer and metastatic breast cancer, that inhibit the tyrosine kinase activity intracellularly. Next slide, please. So again, within the context of antibody-directed cytotoxic drug conjugates, the antibody drug conjugates like TDM1, for example, you have a monoclonal antibody like trastuzumab that facilitates the cancer cell-specific binding of the ADC. That receptor-mediated internalization takes place through natural processes, and perhaps, as we showed in I-SPY, even receptor phosphorylation mediated based signaling. We have lysosomal cleavage of that linker intracellularly as the receptor is recycled or even catabolized for the amino acids for cellular growth. That lysosomal cleavage then releases that payload, it escapes to the cytosol, and then depending on the MOA of the payload, say, for example, topoisomerase 1 inhibition with deruxtecan as the payload, we then get forced apoptosis or mitotic catastrophe that result in cellular death. Next slide, please. So HER3, as alluded to, is not only a very interesting potential actionable target and has its own drug target ecosystem, but it also is very important in its known role for treatment resistance. So if we look at therapy resistance to a plethora of different types of drugs, different tumor types, we have resistance mechanisms that ultimately point strongly in many ways to HER3. So if we look at in hormone-based therapeutics, tamoxifen, fulvestrant, anti-androgens, we have resistance mechanisms in both breast and castration-resistant prostate cancer that results from HER3 biology, either through, say, androgen receptor stabilization by HER3-mediated transcriptional activation of the AR gene, or through increased HER3 and ligand expression itself as a resistance mechanism to drugs like fulvestrant, and as well as in other solid tumor types other than breast, and colorectal, melanoma, and actually multiple tumor types where you have targeted agents like cetuximab targeting EGFR or MEK-RAF inhibitors like vemurafenib. We actually are seeing increased circulating ligand, irregulin, and HER3 activation or transcriptional upregulation of HER3. Or say with trastuzumab, you actually see an increase in receptor tyrosine kinases that heterodimerize with HER3, like HER2 and IGF-1 receptor, and then other chemotherapeutics like dox and paclitaxel, where you have, again, upregulation of the ligand and HER3 activation. So this is why I was asking Dr. Singhi about the potential in the future for actually looking at HER3 and perhaps even neuregulin expression levels in the context of resistance mechanisms in patients who are progressing from these therapeutics at the appropriate line of therapy. Next slide, please. So looking at HER3 and resistance with small molecule inhibitors in lung like gefitinib, or known with breast cancer for both lapatinib and neratinib, which are two dual kinase inhibitors targeting both EGFR and HER2 for both lapatinib and neratinib. And of course, gefitinib is an EGFR receptor tyrosine kinase inhibitor. The resistance mechanisms that have been very well characterized, actually, all are pointing to HER3 signaling. Now, in the gefitinib, it's a HER3 MET amplification-based resistance, or with lapatinib, just simple upregulation of HER3 and the ligand. And of course, with neratinib, we're seeing the inhibition of the HER2, HER3 lysosomal degradation by sortilin-related receptor. So all of these with different kind of inputs, but all leading to HER3 as the primary culprit in developing resistance to multiple different receptor tyrosine kinases that at one point or another work with HER2 and HER3. Next slide, please. So kind of continuing from our last panel discussion, when we think about treatment and resistance with HER2 targeted therapies, it would be great for say the Dr. Pishvaian and Dr. Liu, as from a medical oncology perspective, maybe to discuss a little bit about how they're sequencing the context of looking at HER2 at front line or second line or third line, depending on the tumor type, and then how these new insights into resistance with say HER3, how you're navigating that space as far as targeting and getting patients into different clinical trials with different MOAs that perhaps can overcome those resistance. Maybe Mike, if you want to take it first, and then Dr.
Sure, I'll go first because my space is definitely a little smaller. But it's interesting because in the GI cancer space, there was so little HER2 targeting until the first trial with trastuzumab in gastric cancer, where it clearly improved overall survival. But then there were several years of failed trials trying to look at second line and beyond HER2 targeting with lapatinib, with TDM1, and why all of a sudden some of the newer therapeutic options, especially the ADCs, are showing real promise, it is interesting to me. I think it reopens the door to trying to look at multiple other ways of targeting these HER2 overexpressing tumors. And really, we haven't talked much about it, but in the gastrointestinal cancer world, gastric and gastroesophageal cancers, biliary cancers, even small bowel cancer, and then certainly colorectal cancer definitely have a distinct population of HER2 overexpressing tumors, and it really should be looked for to be able to be targeted. But Dr. Liu, I mean, your field's experience is much wider. How have you even tried to figure out how to sequence all of the therapies?
Sort of a loaded question. So in breast cancer, I mean, we have the advantage in some ways because many of the HER2 targeted agents have been evaluated specifically in this space. But what that also means is that with each new approval, we have increasing conundrums of what to do. Our sequence of therapies is really defined by the clinical trials and, in what setting was the drug or combination of drugs evaluated. But the reality is we need to be smarter than that. And so really the way to navigate this is going to be through biomarkers. And so very grateful for the efforts of Dr. Petricoin and Dr. Singhi, who, from the research side to the clinical side, will bring these to us so that we have the tools for our practice. And the question isn't just necessarily about sequence. It's about duration of therapy, and it's about combinations of therapy. So as we have newer approaches to targeting the HER2 pathway, we need to figure out, exactly what do we need to be targeting when we're targeting HER2, and what things can we combine together to be most effective. Because it's not just about sequence and dragging things along. It's really, we'd like to get to a point where we're not dealing with metastases, macro or micro, and that we're doing this right in the curative setting.
Well, and I think that's a good segue to another question that I had, which is, you were my boss in the time that the trastuzumab adjuvant trial was coming out. And, that was a huge deal. And it's cured many more women of their breast cancer. And so are these newer HER2 targeted therapies going to eventually make their way into the potentially adjuvant setting?
They already are. And you just told everyone how old we are, Dr. But anyway, we already are. I mean, with mechanisms like the I-SPY2 clinical trial that's focused in early stage disease, and other large scale trials, we're bringing HER2 directed therapies more and more into the adjuvant and neoadjuvant setting. And I'll stress the neoadjuvant setting for HER2 positive breast cancer is critical for us because although we don't have the refined biomarkers to predict what therapies might work, using that endpoint of pathologic complete response, which is a hard endpoint for us pathologically, but if we can identify surrogates through the blood or through imaging, like with MRI, we might be able to better tailor therapy for our patients.
Well, again, we're following in your footsteps, but in the GI cancer world, for example, one area that comes to mind immediately is biliary cancers, which unfortunately are still relatively deadly cancers. Yet we have, especially gallbladder cancers that are high overexpressors of HER2, relatively speaking, and to try and potentially add HER2 targeted therapy post surgery might be being approached. Dr. Singhi, do you get asked to test for HER2 in surgically resected samples on a routine basis?
Actually, yeah, in fact, we do. We've been detecting HER2 amplification as well, as you mentioned, in gallbladder cancers and intrahepatic cholangiocarcinomas. And yeah, we've seen responses pretty impressively. We've had patients that have lived, with stage 4 cholangiocarcinoma for years. Unfortunately, though, resistant mechanisms do occur, and it's still questionable what types of resistant mechanisms we're really going to start encountering with therapy with these patients.
Which might bring us to Dr. Petricoin's, model of dynamic phosphorylation testing as the patient goes along in their treatment paradigm.
Yeah, absolutely.
All right. Well, I'm seeing that we've come up to 9 o'clock, so let me kind of just go over a quick summary of what we've learned today, which is, this is just a small highlight slide. We definitely discussed that HER2 testing is encouraged in many cancer types, I think more than we just discussed here today. That testing and alterations can include protein overexpression, gene amplification, as well as constitutively active genetic mutations. HER2 positive cancers are aggressive, but then there are also multiple targeted agents available for targeting HER2 overexpression, including antibodies, small molecule inhibitors, as well as antibody drug conjugates. And then with regards to HER3, a more recently targeted member of the Her family that definitely dimerizes with HER2 and become a potent oncogenic driver, and definitely is implicated in treatment resistance. So hopefully novel therapies targeting this resistance pathway will even further extend the durability of being able to target HER2 and the Her family proteins in general for different types of cancer. And with that, I just can't thank enough the faculty that we've had today. Dr. Singhi, Dr. Liu, Dr. Petricoin, you all are true experts in your field, and I really am honored to be able to have you on our Tumor Board Tuesday live webinar for the first one that we had, and I hope that many more come along in the future. Let me remind our audience that to be sure to claim your CME credits by completing the post-test and evaluation form at www.integrityce.com/TBT-eval1. And don't forget to check the tutorial on the prevalence and the role in genomic testing of Her family receptors in patients with cancer. That'll be available right here in a week on Tumor Board Tuesday, next Tuesday, December 7th, 2021. And with that, I thank you all and have a great night.
Thank you.
Thank you.
Bye. Thanks.